Welcome, everyone. I'm Hannah Hendricks. I'm AMSA's national president. I see some familiar faces out there, so I'm guessing most of you are pretty familiar with AMSA. But for anyone who's not, we're the oldest student-led association of medical students in the country, and our mission is to inspire a community of future physicians through education and advocacy. We've been really busy this year, especially lately with actions related to the Women's Health Protection Act and drug price negotiations and Build Back Better. And we'd love to see anyone who wants to get involved get in touch. Tonight, we're proud to be hosting our third installment in the After Hours Speaker Series. This month, we're joined by Dr. Kevin Fikkincher, who will be speaking about reinventing and reintegrating primary care. Dr. Fikkincher has led a wide-ranging career in various healthcare leadership positions related to the delivery, technology, policy, and association sectors. He continues his work in healthcare by providing strategic and advisory support to organizations throughout the nation, with a specific focus on technology applications, informatics, telecare services, and leadership development. In addition, he's been actively involved in state and national politics for nearly 40 years in a diverse array of roles, extending from his involvement as a national medical student advocate for the Carter presidential campaign, as a local candidate for the state legislature in his home state of North Dakota, health policy advisor for Joe Biden's first presidential bid in the late 1980s, service and policy development, and as a surrogate speaker for the Clinton presidential campaign with a focus on healthcare issues and policy. For the last decade, Dr. Fikkincher has focused his time and energy on developing and implementing various telehealth and telecare initiatives, especially as they relate to primary care. A University of North Dakota School of Medicine graduate and former AMSA national president, Dr. Fikkincher is a family physician by training and is a certified physician executive with both the American College of Physician Executives and the American Academy of Family Physicians. Thank you so much for joining us tonight, Dr. Fikkincher.
Thank you very much. It's a real pleasure to have this opportunity to talk with all of you and to share some thoughts around the issues related to primary care. Thank you, Hannah, for that warm introduction. I should point out that, of all the things that she mentioned, being president of AMSA was one of the most exciting, the most challenging, and the most growth that I went through in my career. Matter of fact, it's not well known in AMSA world, but I was the one and only president-elect of AMSA. In my year where I was elected president-elect, but there was a surge of individuals who were against my presidency, who decided to do away with the position. So I basically stepped onto the floor of the House of Delegates and volunteered to resign and run again the following year, which I did and won overwhelmingly. So it was a good experience. I learned a lot out of it. So tonight we're talking about primary care. And let me just pull up my slides and share with you. Can you all see those? Is that coming through? Good.
We can.
So I want to talk with you about what I perceive to be the disintermediation and dissolution of primary care, and how we need to really take this issue seriously, because I think it's an extremely important issue for the future of healthcare, and figure out how we can reintegrate and reinvent, if you will, the specialty of primary care. So let me just try to move this forward. Why is it not doing that? There we go. This is a very famous painting. It's called The Great Wave of Kanawaga. And it is a Japanese painting, a print, if you will. And it represents a painting of a tsunami wave. And one of the things that's important to know about tsunami waves is that they basically start out in the middle of the ocean, and there's a disruption that occurs in the surface of the earth. And through that disruption, a sound wave gets created, and it dissipates itself through the ocean. It's only, though, when that sound wave gets close to shore, that it creates a massive wave, a wave of destruction that you cannot stop. You cannot change directions. on that wave. And I use this as my metaphor for what's happening in healthcare. We're facing a tsunami wave of changes that are occurring within the healthcare sector, across all sectors, really. When you look at industry, and I'll talk more about that in a little bit, but in healthcare in particular, because of its societal importance, this is becoming a major issue. And that Chinese anagram there stands for the word tsunami. So George Eliot said, life is measured by the rapidity of change, the succession of influences that modify the being. And I would argue that we are in a period of very, very rapid change, and that it is modifying our whole notion of what does it mean to be a physician? What does it mean to practice medicine? What does it mean to deliver care? And that we need to accept the fact that that rapidity is going to continue and try to figure out how to manage it, how to deal with it. And I would argue that really the change that we're facing deals with sort of four sectors. One is at the global level, we're seeing significant change. We're seeing that in healthcare. When I was a medical student and when I served as president of AMSA, we did not think about the fact that healthcare might be delivered by specialists who lived in Delhi or other places. That wasn't on our radar. So we're seeing globalization, if you will, of healthcare services. We're seeing societal changes. Healthcare now consumes 20% of the GDP of this country. That's the largest percent of GDP of any country in the world. Not only that, but it also represents, if you take Social Security and put that with healthcare, we now represent more than 50% of the entire federal budget. That's massive. That's massive. So that has a societal impact. And then there are system impacts. I mean, the fact that we now have very large systems that are managing the care and that are organizing the services and delivering the services and bringing them to not just a region within a state, but to multiple states across multiple geographies. And then finally, there's both the provider impact and the individual impact. So I would argue that all four of these different areas need to be considered as we think about how are we going to manage the future of something that we call primary care. And at the present time, my argument is that we are in the process of disintermediating what primary care was originally thought to be about, which was, and I'm a family physician, I was trained in primary care. It was really brought about to be the specialty that could be the coordinator, the organizer, the specialty that really cut across all the various sectors. And we're seeing the disintermediation of that. We're seeing it taken apart piece by piece. And it's being taken apart by what I would characterize as sliver solutions. So we've got a diabetes program here. We've got a hypertension program over there. We've got an osteoporosis program. We got a, pick your favorite medical problem site. We've got kidney problems, renal problems. All of the pieces, all of the elements of what it means to be involved in healthcare are being sort of picked apart, and they're not connected. And when they're not connected, we create greater costs, we create duplication of services, we create information that falls to the floor. So that's a real problem. So the question becomes how to prevent that disintermediation. How is this happening across the spectrum? Well, I would argue that it's not just happening in retail services. It's not just Amazon that's causing this. It's not just Verizon and AT&T that are causing this. It's not just happening in our politics and in the media. It's happening across the board. And in particular, it's really happening in healthcare and especially in primary care. So we need to alter our perspective and really think about how the current situation, in particular with the overlay of the pandemic, is really causing us to think about the seasonal change, if you will, and what we need to do to solve the problem. Well, in healthcare, we've been through lots of revolutions, and I was going to go through all of the revolutions that have occurred over time, going back to the agricultural revolution, There's about 10 of them that are really important in the history of mankind. But I thought, let's just talk about the medical revolutions that have occurred. Edward Jenner, you all know about that, in 1796, inoculated for smallpox and created a virus vaccine. And it was in May of 1980 that the World Health Organization declared smallpox eradicated. Now, why I point that out is that that's occurred in my lifetime. I mean, before 1980, we thought about smallpox. And I remember people asking me where I got this scar that I had on my shoulder. Well, it's because I had a smallpox immunization. People don't ask that question of younger generations. So that was one change that we experienced. There's also the change that occurs as a result of anesthesia that was being delivered starting in 1846, and that changed our whole notion of how we're going to deliver surgery services. Germ theory was established in 1861. I don't know if any of you have ever been to London, but they have a pump where John Snow actually first discovered cholera was being spread and from contaminated water at that pump. And that's the John Snow pub, by the way, is right behind it. So germ theory was created, and that had a major impact on the way we think about how healthcare services are delivered. 1895, we developed medical imaging. Then penicillin came along in 1928, and that is considered by most folks to be probably the most important of all the changes that have occurred, because all of a sudden we had antibiotics. And we had organ transplants that started in 1954. And then simultaneously in the 1970s, we had stem cell, and immunotherapy changes that have occurred. And again, radical change that really created a revolution in how we think about healthcare. 1980s, we had MRIs, which, I think the younger generation, you rely upon those. We didn't have those when I was a medical student. And then we had the antiviral start in the 2000s, and now more recently, the mRNA model, which is radically changing our whole notion of how we're not only going to take care of viruses, but how we're going to engage in cancer care, how we're going to engage in cardiovascular care. It's really radically changing our whole notion of what it means to be a healthcare delivery person. So my point in all this is that we're seeing an acceleration, if you will, of the pace of change that's occurring with technologies. And finally, it's not just the acceleration of the pace of change, it's also an acceleration of the adoption of the change. So mRNA, literally, the scientist established what the virus was, and we had vaccines available within 3 months. That is amazing. That is absolutely amazing. That kind of change is only going to happen in other areas as well. So how we adapt to that and how we relate to it, I think, is one of the critical questions that we need to be asking ourselves. And it's within this context that I've been really concerned about primary care. And, what does it mean to be a primary care physician in today's world? So on top of that, we have all these other problems that we're dealing with, so it's not just the technology of medicine and all that entails. We also have an aging population. I can tell you very honestly that I have consumed more healthcare services in the last 18 months than I consumed in the previous 68 and a half years of life. And I'm a typical boomer. I'm typical. And you know what? It's only going to accelerate. I'm convinced of it. So the aging population, we're seeing high risk, we're seeing complex care, we're seeing an explosion of cost because of the number of us that are in the system that are really overwhelming. So I think, some of the things that are being proposed by President Biden are really crucial for helping to get a handle on this particular problem. But it's not just that. We're also involved in the global economy. I mean, you've heard that from lots of folks, so I'm not going to spend a lot of time on it. But clearly, the global economy has had an impact. And then finally, I'll be honest with you, patient frustration. Having been a patient, I can tell you that there are really periods of frustration that I've had in that last 18 months period where I didn't feel like I was being communicated with, I wasn't being dealt with as a patient, and I wasn't really getting the information that I needed to be able to process. And things were happening around me, tests were being done on me. And, patients get frustrated with that kind of an environment, that kind of a situation. So, how do we deal with that? And on top of that, we have an increasing shortage of primary care providers. 1/3 of all the primary care providers that exist today in the year 2021 are going to disappear by 2025. 1/3. That is physicians, nurses, nurse practitioners, and other clinicians who are involved in the primary care sphere. That's huge. That's massive. And just look around. It's already happening in the rural areas of our country. If you go to the Dakotas, if you go to northern Maine, if you go to, rural Wyoming, go to the reservations, go to all these rural areas, you're going to find that that already exists and that it's a major problem in terms of how those communities are being able to manage their services. And it's being compounded by the fact that we have this pandemic going on. We're really experiencing a situation where we've got a burnout of the primary care providers. Yesterday, I was talking with a very close friend of mine. I've known him for 40 years. His wife is a primary care nurse practitioner. She walked in yesterday morning and quit her job. She quit her job because she's so frustrated with the management infrastructure and the inadequacies of that infrastructure. She just said, I've had enough. I can't deal with it anymore. And he was really surprised that she did that. I guess she did it on the way to work. She decided that that's what she was going to do. So I think that this is a very real phenomenon, and we need to, figure out how we're going to deal with it. So my position is very much like this gentleman. Whoop, I shouldn't have done that. There we go. Who, oh, come on, Kevin. Marcel Proust, can you hear me? Okay. So Marcel Proust, I'm not sure why he is not progressing. There we go. Marcel Proust said, the real voyage of discovery consists not of finding new lands, but of seeing the territory with new eyes. And I would argue that that's what we need to be doing. We need to be looking at the territory and trying to figure out how to look at this in a new way to actually solve the problem. Well, part of the solution, I believe, is to really engage in an activity that can reintegrate, if you will, the traditions of face-to-face care, but to do it with telecare, telehealth, and to bring those two spheres together rather than pulling them apart. And that means that we have to really rethink both of those models, because the existing telemedicine programs, as I already mentioned, are increasingly a bunch of splinter programs. I mean, Teledoc does wonderful work, but what Teledoc doesn't get communicated to the primary care physician that you're a part of, or Village MD, or Raleigh Health, or pick your favorite organization. I mean, none of them really connect up with the face-to-face component. And the face-to-face component, they don't have the infrastructure, they don't have the capabilities, they don't have the talents to be able to assess the technology. So they're not adopting technologies at the pace that is needed. So how do we solve that problem? That becomes very important. The other thing is that increasingly it's recognized, particularly as we move towards value-based reimbursement, that not everybody needs to see a doctor. Matter of fact, doctors are not always the right folks for solving problems. That really what we need is a team approach that involves members of the team working together in a collaborative way to really facilitate and deliver care. When I was in practice, I had a nurse practitioner, I had a pharmacist, and I had a social worker in my practice. The four of us really functioned as a team. The nurse practitioner and I would share my OB patients, in that she was much better at education than I was, and I, tended to get into the data, and so we would alternate seeing the patients, every other visit, and that worked really well. And for those patients that had particular social problems, we would have the social work get engaged, or for my patients who had complex problems, we would have the pharmacist get engaged. So having a team approach really makes a big difference. But at the end of the day, there's something to be said about the touch of your physician and actually helping to heal patients. I have to tell you, I've had an observation as I've been actually talking with some of my colleagues about this recently, because as I mentioned, I've been using the healthcare system more appreciably here in the last couple of months than I did previously. So I've been to a bunch of different physicians. Matter of fact, I've been to 7 physicians. So, it's a complex problem, but it's a very solvable problem. But only one of them touched me. That had a powerful impact on me. Only one of them touched me. The rest of them were sitting at their tables, typing away, doing their thing, gathering data, putting information into the computer, talking to their computers rather than talking to me. And I found that to be an interesting response. So I throw that out there because that's something that needs to be thought about. Is that really what we want to do with patients when we're seeing them in the office? How do we want to treat them? So my basic premise is touch is not something to be discarded. The other thing that I think we need to do is we need to rethink our notion of what it means to be involved in telehealth. And I think it really involves all 3 of these functions. There's the telemedicine component, which is the actual involvement of clinicians delivering services. There's the telemonitoring piece, which is using devices to actually engage in measurement of mostly biometrics. And then there's the actual telecare, which is using a team to actually deliver services and to talk to people and to get them to use the right kinds of services at the right time in the right place, and individualizing that based on the particular patient. So it's really these 3 things, these 3 elements working together rather than having them done separately. That's critical. This is a model that I put together of, what does it mean to be providing digital services? And I would argue that there is one element that is triage, and there is a lot of care that could be triaged very effectively. There's also a portion that is involved in digital care delivery. That'd be the digital medical piece. And then there's traditional services that are done in emergency rooms or in offices. When you look at primary care, about 70% of primary care can be done on that digital or triage level. It's that 30%, though, that is absolutely crucial, and how you manage that and tying that together with that 70%. That's what represents a more comprehensive model of how we're going to be involved in care delivery. And then on top of that, we have all of the ologies, and not to be disparaging, but they are ologies, and they're important as well. And so how you integrate the information that's derived from those specialties is also crucial if you're going to be able to provide effective digital care. And within that context, I think we would be much better able to manage problems like diabetes, as an example, or congestive heart failure. Congestive heart failure is an interesting example. Patients go into congestive heart failure about 72 hours before they show up at the ER. That 72 hours is a massive, huge window. So to the extent that You can identify somebody who's going into congestive heart failure and get them treated. You prevent them from going to the emergency room and prevent all of the costs that are associated with just simply showing up in the ER. So that's a good example of where interventions like this can work really effectively. So the goal, I think, is to make healthcare better. We need to make it more easier and make it more effective, and using face-to-face tied with virtual care is the way to accomplish that objective. So how do we do that? Well, first of all, I think we need to augment and replace our care delivery practices. One of the problems that we've seen in healthcare is that we create solutions and then we overlay them on top of existing solutions, and we create work on top of work. We don't really rethink our workflow. So one of the more important tasks as we adopt all of these technologies and all these processes is to really think about how do we change our workflow? And that's really particularly important in the primary care space. We need to extend the care delivery capability of providers by deploying, implementing, and managing state-of-the-art virtual services. We need to integrate social determinants as a part of healthcare rather than as some separate function that occurs over here on the side as a referral. And we need to enhance our care delivery practices by supporting efficient and effective tools that give us best practices. So for example, I was talking with a colleague today who's working with a major global system that's actually come to the United States that is looking at how they're going to be delivering services in this country, in the United States. And we were having a discussion around the efficiency and effectiveness of their tools. And what we were discussing was the fact that one of the things that they've developed is they've created artificial intelligence and machine learning on the back end that captures all of the workflow, all of the data, all of the financing, all of the data from every place that affects a patient's care delivery, using that data to create better protocols, better guidelines, better processes. That needs to happen. That's a really critical function. And that hasn't really occurred very much, except in a few instances and a few organizations that are beginning to really take that on as a serious objective. So using artificial intelligence and machine learning as a tool for helping us to solve some of these problems is quite crucial. So let's take a little bit deeper dive. I think we need to offer what I call the comprehensive coordinated care model, which integrates. We need to use the team approach. I've already talked about that. We need to really get, and I would argue AMSA should get on this one. You need to get Congress to really start to have an open discussion about creating an open digital platform for healthcare, that we need to have comprehensive sharing of information and data. It can't be hidden behind Epic or Cerner or, pick your favorite one. That is a big impediment to the kind of things that I'm talking about, and we need to solve that problem. We also need to see the collaboration of local and regional, and I would say even national partners, as we tie together the face-to-face with the virtual, and then engage in this analytics function that I talked about. So the model that I've really adopted as part of my comprehensive coordinated care model is what's called the P4 medicine model, which involves being focused on preventive care, really looking at how that care can be participatory. In other words, how do we involve patients in that? And then personalizing it around the needs of that particular individual. And then also developing a predictive model so that we can be better at defining which patients have particular kinds of problems. And that's what the comprehensive coordinated care model is all about. And if people are interested in that notion, I've got some white papers that I've prepared on that particular idea, that concept, that I'm very willing to share. And then finally, there's also the social determinants, which are a lot of these elements, that are really important. And I'm not going to spend a lot of time on it because I want to get to the Q&A and have a discussion around that. The team approach is really important. I've already outlined what I consider to be sort of the core team. Some people would add a nutritionist to that team. They might add maybe some other individuals. The second level would be probably occupational and physical therapist, speech pathologist, therapist, and dentist, perhaps. And then finally, some of your high demand specialty areas. Now, my wife is a Mohs surgeon, so she's a dermatologist. Actually, I'm very proud of her. She's the past president, immediate past president of the American Academy of Dermatology. She's only the fourth woman in 85 years to be president of the specialty that now has almost 57% of the population being women. So it's about time, I would say. And so anyway, dermatology is one of those areas where anything that's a digital specialty, so dermatology, radiology, even cardiology, invasive cardiology, neurology, all of the ologies, if you will, are prone to be susceptible to being involved in that kind of a model and being pulled in as team members. I've already talked about tying together virtual with face-to-face. That's important. Continuous remote patient monitoring is important. I mentioned that I had had a medical problem. Actually, what was happening is I noticed that, this is now 6 weeks ago, that I was having these periods where all of a sudden I get really tired. It's like, whoa, I gotta, what's going on here? I'd take my pulse and my pulse was running about 42, 44. Sometimes it was even down in the 30s. And I was saying, wow, boy, am I a healthy guy. I've been exercising, I've been riding my bike. I've been doing my walking. Boy, am I doing a good job. My wife says, I don't think that's what that means, Kevin. And in fact, I had AV dissociation. How was that discovered? Well, they put a Zeo patch on me. They sent me home. And the next morning they called me and said, Kevin, how you feeling? I said, well, gee, I'm feeling fine. Why? I said, well, let me talk to your wife. So they sent me to the hospital. I have a pacer now because of the AV dissociation. So that's an example of continuous remote patient monitoring that really changed my life, made it better, solved a problem, and did it like that. So it's tying that together with artificial intelligence and machine learning. Why do I tie it together? Well, in my case, it was really the computer that said, hey, Kevin's got a problem. Let's notify the cardiologist. The cardiologist looked at the strip and said, boy, we got a problem. And so that's an example, I think a very acute example that is very relevant in today's world. And there's lots of others like that we could point to. So it's also really another hard issue, which is we really need to change the model for financing of healthcare and move towards a value-based reimbursement model. The more I talk with some of my colleagues around the country, around the world, it's becoming increasingly clear that if we don't move towards a value-based model, we're going to only continue to consume more and more resources. And that, at the end of the day, is going to be an unacceptable option for society. So we need to figure out how to move in that direction. I will never forget when I was a young physician, early in my career, and one of my colleagues stood up. I was trying to promote some changes in how we were going to deliver care. And he stood up and he said, Kevin, you don't understand one very important fact. I said, what's that, Gary? He says, it's not the money, it's the money. But I've never forgotten that because he's absolutely right. It's not the money, it's the money. Money drives the system. We need to figure out how to solve that problem. And that means we have to change the system so that we're not paying for piecemeal services, we're paying for comprehensive, coordinated care. So if we do all these things, I think we will move in a direction of really towards integrated and managed virtual care delivery that supports primary care practices. And we will also, very importantly, move towards value-based payment models as a way of financing the care that we want to deliver. And it's within that context that I think we can make healthcare better. One of the things I would want to end with is that very early in my career, at my residency, one of the things that I did as a result of the urging of my residency director said to me, Kevin, you really need to sit down and figure out what your purpose is going to be in healthcare. I thought about that and I said, what is my purpose? What am I doing here? And I decided that my purpose was going to be, I want to make healthcare better. So my entire career has been focused on that purpose. How do I make healthcare better? I've been involved in different activities, different areas, etc. I've done different kinds of things, but all of them come around to the fact that they were all focused on how do we make healthcare better. And I would encourage you as students who are entering the period where you're going to have to decide what is your purpose in being a physician, to think about that. And what is it that you want to do for yourself, but also for the people that you're going to be caring for? And how do you want to do that? So thank you very much for inviting me to participate. I have to tell you, this has been for me personally one of the most exciting things that I've done in a couple of years. And it's to talk to the medical students. I always enjoy talking to students, but in particular to talk to the AMSA students, because you're the ones who are going to make change. I know that one of you that's listening is going to help make the change that needs to occur. And here's my contact information. Feel free to reach out to me. I told Pete Thompson that I would send a PDF to him. And if you want a copy, you can get a copy from Pete. So with that, Hannah, I'm going to stop talking and I'll take questions.
Thank you, Dr. Fikkincher. That was very informative and definitely shed some light on some new perspectives around issues that we've known about in primary care. So I'm going to start us off with some questions, but absolutely for our audience, if you have questions, please drop them in the chat or send them to me and I'm happy to relay them to Dr. Fikkincher. To start us off, one of the questions that I had was, how is this issue of splintered care versus managed care, how is this affected by moves away from physician-owned private practices that used to be very common, especially in primary care, and these moves towards like health system-owned practices and physicians as employees?
Well, I think the splintering of care and ownership of practices are probably two separate issues. When I talk about the splinters solutions, what I'm talking about is a lot of the virtual services that are being deployed that are taking little pieces of healthcare that are totally disconnected from the primary care process and are offered as a solution, if you will, to care delivery, when in fact they are perhaps an elegant solution for a very thin problem, but the very thin problem is related to 5 other problems that exist within the individual, and how do you tie all that together? So there's that. In terms of the corporatization of healthcare, which is the other side of the equation that you're talking about, I think that, having been an individual that helped to establish some very large medical groups, I mean, when I was at Catholic Healthcare West, which became Dignity, which became Common Spirit, I was involved in helping to put that together. I mean, I actually was involved in doing that. I do believe that that is not necessarily a bad phenomenon. It depends on where the money's coming from and how it's going to the providers. In too many cases, what I've seen is that the incentives are around doing things to people, performing more services, etc. And in that context, that's not good. And in particular, a lot of the private equity that's being thrown at medicine in today's world is really pushing physicians in that direction, where they say, "Oh, we'll give you a contract that takes you through the next 10 years and keeps you level, but here are some of the performance things that you need to do." And those kinds of situations, I think, are actually destructive to the whole notion of what I'm talking about in terms of movement towards value-based care.
Sure. And I think the way that you describe these health systems, and from what I know personally, it seems like there's some potential to actually facilitate managed care in a
Yes.
group that can offer many different options for care.
Right.
Like, say, if your primary care office and your telehealth visit
Yep.
were managed by the same system, it might be, especially in our splintered digital
Right.
health records place that we're in, where not every health record is available on every EMR.
Absolutely. As a matter of fact, I'm working with a major network of FQHCs, federally qualified health centers. Federally qualified health centers are really centers that are created as a result of funding from the government to provide services to Medicaid and Medicare populations that are underserved. And so the FQHCs have a very important role in delivering care to populations that wouldn't have access to services. What's interesting about the work that I'm doing with them is that we're in the process of really trying to do the kind of thing I was describing, which is bringing together the digital and the virtual care services so that they can actually embrace value-based reimbursement, take value-based contracts from the insurance companies that are in their particular geographic area, and really move in the direction that I'm talking about. I actually think the FQHCs are going to be some of the forerunners of where we need to go into the future.
We had a great question in the chat. As I'm sure you're aware, AMSA has been focused on health equity for some time. And the question is, how can telehealth improve or worsen racial disparities in primary care, especially during this pandemic?
Well, I think it can potentially improve disparities in that what it does is it allows you to identify problems sooner and develop or deploy interventions sooner as a result of identification, so that you can get care delivered, and it does it more efficiently and more effectively. So because of those three things, you're actually able to deliver services to a population with fewer fiscal resources, if you will, or same fiscal resources, and then save a little bit of dollars for developing other care. And then if you put the overlay of the social determinants that I was talking about, you really address some of the problems, because social determinants, my gosh, in primary care represent probably 50% of the problem. I mean, it's the fact that people don't have transportation to get to the clinic. And so by offering a virtual component, they don't necessarily have to come to the clinic for all of their visits. It is making sure that they have the right kind of housing situation, that they have the right kind of support services, et cetera. So I do believe that the kinds of things I'm talking about would actually, and that's the reason actually that the FQHC that I'm working with, this network of 42 clinics, by the way, it's not just a small group, it's a large network of FQHCs. 42 of them are really coming together because they believe that this will really help them do a much better job of delivering care to the population that is underserved and that they take care of.
Thank you. Here's a great question. What do you see as the biggest roadblocks to a more integrated healthcare model? Okay. Yeah.
It's money.
Mm-hmm.
Money always gets in the way. And it's the incentives of the money.
Mhm.
I really think that is probably the single biggest and largest impediment.
Do you see a bridge from where we are to where we need to be?
Yeah, I mean,
It sounds like you're talking about, and I think I am not overstating this, kind of a revolution in healthcare that would mean uprooting a lot of systems. And we know we would love to uproot the system, design it better from scratch, and make it not about the money. But what do we do to get from here to there?
well, first of all, I don't think it's going to happen every place simultaneously. I mean, so I don't think that is necessarily what's going to happen, but we are seeing across the country certain geographic areas that are really embracing the ideas that I was talking about, particularly around value-based care. And those regions are the Northeast, the Mid-Atlantic, the Northwest, Northern California, and the rural areas. The rural areas recognize that, because they don't have enough primary care providers, adopting this kind of a model makes a lot of sense for them because otherwise they can't deliver any care. So those are the areas that I think we should be focused on, is trying to help them move in this direction. And then by them moving in this direction, they become the exemplars for efficiency and for effectiveness. And I also believe that there's another pressure that's out there that is really going to push the equations that I'm talking about further down the road. And that is the fact that many of the states are increasingly facing significant budgetary problems. Those budgetary problems, in part, are driven by the fact that Medicaid costs continue to rise, and they're responsible for those Medicaid costs. I know that this is a big issue in the state of Maine, where I live now. And the question becomes, what can we do to solve that problem? Well, to solve that problem, we need to rethink how we're going to be delivering Medicaid services. I don't think we're going to do away with them. So let's figure out how we can be more efficient and more effective. And we are seeing that kind of a discussion begin to occur. So, and I don't think it's going to happen in other geographic areas where, they're not quite ready for this conversation yet. I would be, I could tell you which states I think those are, but I'll let all of you figure that out.
Thank you. Our next question, we have someone who's interested in how we overcome patient skepticism of virtual interactions, particularly among older patients.
Mm-hmm. Actually, older patients are the ones who are embracing the use of these technologies almost faster than the younger population. When you look at the data, it shows very clearly that the older generation really likes, and it's partly because of the pandemic. I mean, the pandemic sort of forced the issue, right? But like my mother-in-law, she's 90 years old, and she would much rather have an interaction with her physician from her home rather than having to climb into my car and travel down to the physician's office and have me go with her. I mean, she'll do that if that's what's needed, but her preference is to try to solve the problem on a virtual basis. So, I do believe that the older population is increasingly accepting of this because they're finding that it's good. Now, if it is disconnected from their primary care person, the person that they talk to, then they don't particularly like it. So that's where we're seeing the disconnect. So having the integrated model is an important part of that.
I know even in the hospital, this is in no way the exact same issue, but by the time the medical student and the resident and the physician have interviewed the patient, They're
Yeah.
tired of telling that story. And I can imagine
Right.
it's similar, seeing someone on telehealth who's not connected to your primary care provider, who then refers you to your cardiologist.
Right.
I'm sure that can be exhausting.
Yeah, it
It
can
just
be.
seems like there's a better way.
Yeah, I got
Yeah,
a short story I got to share. So
sure.
I was a third-year medical student, and I was at part of our training when I was at North Dakota was at the University of Minnesota. And I happened to be a medical student under the tutelage of Dr. Franciosa, who at the time was one of the specialists in congestive heart failure and other kinds of problems associated with severe cardiovascular disease. And I had the opportunity as the medical student to do the first interview with the patient. So I did this comprehensive interview. I did a like stellar physical exam. I was with that patient for 4 hours. And by the time I was done, Frank thought I was the best thing since sliced bread. So we go to rounds the next morning and we walk into the room. And Dr. Franciosa says to Frank, well, I think we need to, really take you down to the lab and we need to do this special procedure. And it's it's sort of experimental, but I think it's really important. And that was an exam nowadays, which would be common. And Frank turns to Dr. Francis and he says, well, let me ask my doctor first what he thinks. And he pointed at me and I was his doctor. So those relationships, are important. It's that relationship.
Yeah. Here's a great question from our
Yeah.
audience. As AMSA members and future physicians, how can we start the conversation with Congress about equal access to primary care and telehealth? It's a big question.
That's a big question. First of all, primary care services need to be valued properly. And they are not necessarily valued properly in the context of the greater system. So we need to advocate that the services that primary care physicians provide and the services that surround primary care that I was talking about are of value and that they deserve fair payments. Now, this is where you get into the conversation of, can you try to do that with the existing system? I think it will be very difficult. So if I was at AMSA, I would argue that you should really start to explore the literature on what constitutes a really good approach to value-based care delivery. Develop a white paper that medical students have thought this through and said, hey, these are the elements of what we think need to be included in value-based care, and go to Congress with that and say, we think the system needs to change. We're the future of healthcare. We want to see this kind of a system adopted. And I would approach it that way. I don't know if that makes sense to you, but I think that's going to be a better approach than trying to do it in more incremental fashion.
Sure. Do you think, I know one of the things that AMSA has been advocating for a long time is increased access to care, and that advocacy has taken many forms over the years. Do you think the end goal is something like maybe not specifically Medicare for all, but a single payer system or universal access? And how does that change this issue?
Well, I personally believe that it's going to be very difficult to advocate for a single payer system. That has been around for my entire career, and it hasn't happened yet. So, advocating for that, certain people believe that that's the way we got to go, but they've been advocating that for 50 years and it hasn't happened. And I don't think it will necessarily happen. I think redoing the system around the way I'm talking about is probably a better model, and to use the economic pressures that exist on government, on private industry, on others, on small groups, etc., on medicine itself, to really bring about the change that needs to occur. So, I mean, that would be my thoughts on that one.
Sure. Another question sent to me from an audience member.
Mhm.
Are there examples of other countries that have employed a model based on value-based care, and how might we test a model like this?
Yeah, there are some examples. So I wouldn't say that it's a perfect example, but Germany has done actually a lot of work in moving in this direction, and has developed a payment model that is built around notions of value-based care, and has demonstrated much more significant efficiency and effectiveness for the biggest bang for the buck, if you will. So that'd be one country that I would point to. I think that the Nordics have been particularly successful. Now, people say, well, the Nordics, they don't have the same social problems that we have in other areas, which, maybe there's some elements of truth to that. But they have been relatively successful as well, with similar but somewhat different approaches. So I think there are some examples out there. We've also seen within our own country, regions of the country, that this has really been fairly successful in moving in this direction. So that's the reason I pointed to those geographic areas I talked about. It was because those are areas where we have seen insurance companies, as well as payers, other payers and providers, really begin to adopt the model of value-based care. And, for example, I think the University of Michigan has been one of the universities that has done a lot of work around studies of value-based care delivery, and has developed some core elements that they think are important for including in value-based care models. So that might be one place to look as well.
Great. Thank you for those recommendations, places to learn more about value-based care, and where we can really start to advocate for a better model than we have.
Yeah.
We're reaching the end of our time tonight, so I want to thank you, Dr. Fikkincher, for your time, and thank our audience for being here with us. We appreciate you. We appreciate your time, and we're so glad that you chose to spend some of your evening with us.
My pleasure. Absolutely. Hope it was useful.
Absolutely. With that, we will give the rest of your evening back to you. Thank you all.